Hi, I am going to talk about pediatric neurological issues with children. And so this is a continuation of a lecture that I did in class here in fall 2013. So I'm going to go over the first part of the material rather briefly until we hit seizures, but I wanted to have this whole videotape for you so it'll help you with your study and also your exam coming up. So that's where we're going to start. Just remember with children that there are some considerations that you need to be aware of, and one of those is that you need to check reflexes for newborns, and you've probably reviewed what the reflexes are in OB, but those primitive reflexes, it's important that you identify, do the babies have them or not, or do they keep them longer than they should, especially what we call the primitive ones, like the sucking and the startle, which is called the moro. So check your reflexes of the newborns. Remember also, children under 2 cannot follow directions, so sometimes that provides some challenges for us as providers. Don't forget to see if your children, ask the parents, have they met their milestones? And we went over milestones in the very first for growth and development. Can they have a good head control at 4 months? Can they sit up by themselves at 8 months? Those are just 2 that are commonly tested. But check your parents, see if the client, the baby, has met their milestones no matter what age they are. There are reflexes that are considered pathological after certain ages. An example of that would be the Babinski. And of course the Babinski is the flaring of the toes when you run a pen, some kind of sharp object, up the side of the baby toe and across the ball of the foot. It would, in an adult, it would cause curling. In a baby, it would cause them to flare. And so a positive Babinski is normal in a newborn, but it wouldn't be in a 2-year-old, for instance. So do they have pathological reflexes? Maternal history is really important too. Has the mother smoked, used alcohol, or any kind of drugs, or been exposed to any maternal infections? Those would be things I'd be concerned about for neurological conditions. Do we have a family history of neurological conditions? Anything that would cause concern, like multiple sclerosis or any kind of neurological brain tumors, something that would cause you to take pause. Any health history issues? Has the child had any neurological conditions? Have they had any trauma, head injuries, any exposure to toxins that might cause neurological things like lead, for instance. Lead poisoning is always a concern. When you do your neurological exam for a child, you need to look at different systems, and so that's what the next slide shows. It's the neurological exam. Does the head look symmetrical, or does it look large or too small? So the size and shape of the head. What is the child looking like? And this is, remember we talked about the pediatric assessment triangle, that as soon as you enter the room, is the child's activity and their behavior consistent what it should be for that age, or for some reason are they more lethargic than they should be? We talk about posturing also with neuro, and there's normal posture, which you can see right now sitting up, or are they turned in, decorticate, turned out, decerebrate, or maybe have an arched back with meningitis. The children would have something called opisthotomus, which is a arching of the back. What are their sensory responses? Are they aware of light, of sound? Again, the word symmetrical is always a big word when you're talking about musculoskeletal or neuro. Do you see any extra movements, tics, vesiculations of any kind? Any tremors? Those are all neuro responses. How are their respiratory system? Do you see any slowing of the respiratory system or any other vital signs changes? We'll talk about that later. Any skin and hair changes? Skin meaning, do you see any pricks in the skin that might indicate drug use, or anything that would indicate that they've had a possible substance abuse problem? A newborn with a high-pitched cry can be very indicative of a baby that's been born neurologically compromised, maybe from drug abuse. So high-pitched cry is also there. There's eye changes that might happen. If there's increased intracranial pressure, you could have fixed pupils. You could have sunset eyes. There's so much pressure that both the eyes are pushed downward and all you see are the pupils in like a sunset horizon. Any throat or mouth changes as well. And then what is their muscle activity and coordination? And muscles and neuro go together. Now specifically, vital signs are critical because there's something called the Cushing's triad, and the Cushing's triad has to do with three things. A widening pulse pressure, which is the systolic is higher than the diastolic, and the systolic is going up, the diastolic is going down. If you subtract those two numbers, that's called the pulse pressure. So a widening pulse pressure, decreased respirations, and decreased heart rate are all indicative of increased intracranial pressure or deteriorating neuro. So those are some things that you should keep in mind that are not good signs. You can see also that you have different kinds of breathing patterns that can be because of brainstem injuries or even ketone breathing. So specifically, there's different systems here that are outlined for you. Again, you want to check the skin for needle marks or injury or bites. The pupils, all different size pupils depending on what's going on neurologically. Pinpoint for opiate poisoning. Seizures, post-seizures, they're going to be dilated. Anytime you hear the word fixed, you know that that's not a good sign that some kind of damage has been done, either cranial nerve or a lesion going on. And then the next slide shows some pictures of that kind of posturing I was talking about. Again, decorticate is in towards the core of the body, which I see as the center of the body. Decerebrate is out, and then the other one is opisthotomus. So check the motor response, check posturing, and also the reflexes. And remember, reflexes from health assessment are outside the realm of the central nervous system. So if you have a child that's been in a motor vehicle accident and they have head injury, what would their reflexes be like? Their reflexes should be normal if there's no cranial nerve involvement. So be sure you think about that. All right, an overriding concept for neuro would be the concept of increased intracranial pressure. And what causes it is either there's too much cerebral spinal fluid being produced or there's a blockage somewhere along the line. And remember that cerebral spinal fluid goes up in the ventricles, it bathes the brain, and it goes up and down the spine. So if you have a blockage somewhere, maybe a blockage is a tumor in the child's brain. Maybe a blockage is meningitis, where you have exudate or infected material. Maybe there's the child was in an accident on a bike and hit their head and have blood interfering. Any of those things can cause a brain to have too much pressure. Now, if it's a baby, the good news is that you've got a flexible brain, that they don't have closed suture lines, they have fontanelles that are open, so the brain is able to adjust a little bit, which is awesome. If it's a child that's older and their sutures have closed, then you're going to have more pressure in that brain, so that's when they might put in a screw or try to relieve some of the cerebral spinal fluid. So that's what it's talking about. There's a question here for you to look at. What is the priority nursing intervention if a newborn has signs of increased intracranial pressure? And I'll let you look at that question. So signs and symptoms are different in an infant versus in a child. You can imagine, again, the flexibility of the skull means you're going to have bulging fontanelles or separated suture lines, maybe some scalp veins that are dilated. And the setting sun sign is what I was talking about. The sclera is what you see the most of because the eyeballs are pushed forward and the pupils are down in a setting sun configuration. Of course, you're going to have an increased circumference of the head. So it's really important to do baseline head circumference for babies, and they should be done from the time the baby's born. Usually up till 2.5 years old, you want to measure the head circumference every time a child comes in for a visit. And a baby is going to, if they have increased intracranial pressure, they're going to be irritable, their cry is going to be high-pitched, and they're going to have a hard time maybe sucking, so they're going to have problems with feeding. Now, what do we see in an older child? An older child doesn't have the bulging fontanelles or that kind of thing. So instead, they're going to have so much pressure, they complain of a headache, a very relentless headache. And then they also have nausea and vomiting, and sometimes that's projectile. So headaches, sometimes they have double vision, which of course is called diplopia. Behaviorally, we're going to see the same thing as a newborn, and irritable and restless, but how it comes across is that the child's performance in school is decreased. They could, and that may be one of the first signs, is lethargy and decreased performance. Maybe some memory loss. Now, either baby or child, some late signs of increased intracranial pressure has to do with that Cushing's triad I was talking about. Bradycardia, widening pulse pressure, and slowing of respirations. Those are critical things. And then you're going to see the pupillary changes, maybe a fixed pupil, and some of the posturing that we talked about. Behaviorally, you might see a child that was alert that's become level of consciousness is going to lethargic, or more and more towards a comatose, till where you could have a total comatose person. Decreased motor and sensory response, these are again are late signs of increased intracranial pressure that need to be reported. So level of consciousness is the most predictable and earliest indicator of either improvement or deterioration in neural status. So if you have a child that was lethargic and they start waking up, and remember, if you want a good response from a child, let their parents be involved in asking them their name or telling them, calling out their name. A child is more likely to respond to a parent than they are to a strange nurse's voice. But also it's a deterioration. If you've got an alert child that becomes lethargic, I'm worried about that child. So how does a child respond to their environment? One of the things that we talked about is an indication that you can use for children, particularly older children, is the Glasgow Coma scale. And just to review, the Glasgow Coma scale has to do with eye opening, verbal response, and motor response. Highest is 15. Anyone 8 or lower is considered coma. I'm sure if you need to work in a neuro unit, you are going to use the Glasgow Coma scale. That's just a reminder that children need parents or someone else to help them. Hydrocephalus is a sign of increased intracranial pressure. And as you can see from the picture here, that you've got a baby that's got a very swollen head, and that baby has some sunset eyes as well. Communication versus non-communicating increased intracranial pressure or hydrocephalus just basically means, communicating means that the cerebral spinal fluid is flowing up and down, and that there's no blockage, but there's extra production of cerebral spinal fluid. Non-communicating says there's a blockage somewhere along the system, and that's why that the child has hydrocephalus. So what's the goals for hydrocephalus? They will put in, usually the medical community will put in a shunt. And so you may be the nurse that goes to, helps the child get ready for surgery, or goes into surgery, or receives that child back. But they're trying to relieve the pressure. But if the child has a giant head, they don't want to do that too fast. So they'll do it, they'll regulate it with maybe putting in a shunt. And as you can see from this, there's this is, the ventricles are in the top of the brain, and then there's the tubing for the drainage tube goes down into the peritoneum, so this is called a VP shunt. And then this one is a VA shunt, where it goes from the ventricles into the atrium of the heart. So depending on the child, if they need to grow, what other complications they have will determine if it's a VP or a VA shunt. We also want to make sure that the complications, treat complications. And what would be a complication of too much pressure or water on the brain? Hydrocephalus. Could be seizures. It could be other things that could cause compromise for the child, respiratory issues. We want to manage the problems that the child has, making sure that they come out without seizures, or at least manage those concerns. Some of these kids have long-term psychomotor and developmental issues. So even if they put in a shunt and they've tried to take off some of the fluid, they can still have follow-up problems. Of course, post-operatively, one of the big problems would be post-op infection. So we have to really monitor the child for temperature. Of course, after surgery, we also want to do some head circumference and make sure that the child is stable in that regard. So surgically, they could put in this shunt, and this next slide just tells you about that complications. Really, infection and malfunction are up to 1 to 2 months after, so prophylactically, this child's going to get antibiotics. 80% of these kids survive after a VP shunt, but those that do survive need follow-up care. 50% of them have neurological deficits. That's a high number. So we know that we're saving these kids' lives, but we're going to have to do some follow-up at home, long-term management. So again, supporting these families, supporting these children is really important. Preoperatively, let's do a head circumference. Let's monitor for those fontanelles. A bulging fontanelle is a sign of an increased intracranial pressure. Older children, you're going to look for level of consciousness. After surgery, you don't want the child to be laying on the side where the surgery was, so on the unoperative side. Now, the head of the bed can be flat initially because, again, you don't want to pull that fluid off too fast. It can actually cause a brain herniation. So constantly monitoring the ICP. They'll put sometimes a little bolt in. The child's going to be in pain. You don't want them to have sedatives that would make them have respiratory depression, but you do want to deal with the pain. And if it's a VP shunt, you also want to monitor that belly and make sure they don't have increased size of the belly or anything going on with that. Intake and output's important. Of course, it's post-op care, and you would expect that. All right, another question, getting us ready for the next section on neural tube defects. Another name for neural tube defects would be spina bifida or myelomeningocele. Remember that spina bifida is a term overall, but there's different kinds. There's meningocele. A meningocele means that this picture down here on the left of your slide, it means that there's an outpouching with cerebral spinal fluid in it, but no nerve endings. If it has the prefix myelo, myelo, that means there is nerve tissue, and that's the one here that I'm pointing at with the pointer. If it's an outpouching, it has fluid and it has tentacles of nerve endings. So if that gets repaired, and there's some kids here with some different meningoceles, then if that gets if that's repaired, then there could be damage also to the nerve endings, and that child may have paralysis below whatever area it is. So the thought here is, how do you take care of a child that is born with a spina bifida or meningocele? Well, first of all, we want to make sure it's a good idea, if the woman is carrying this baby, that they see that they have a meningocele so they can do a C-section. The vaginal vault would be too much trauma for that baby. As soon as that baby comes out, you want to lay them prone, maybe a little blanket underneath their legs. You want to protect the sac with some sterile, moist, maybe moist dressings, and protect them from urine and feces, and provide, of course, still do your neuro checks too, head circumference and that type of thing. Provide family support, of course. It's a good idea if within 24 to 72 hours they can surgically repair this so that there's less complications. Your job, though, is to protect from infection and protect the sac from rupturing, which could be devastating to the child. So they could have some shunts and antibiotic therapy and also follow-up orthopedic. After the sac has been repaired, that's the time when maybe the parent can hold the child. You're still worried about infection and trauma to the incision site, but continue with your head circumference and your neuro assessment for that child. Got another question in here. So later, this child may have paralysis below wherever the sac was repaired. So they may need wheelchairs, they may need bladder support, and other things that you can bring to support the child's growth and development in the family. So know what the resources are and what they're available. Teach the parent the signs and symptoms of how a shunt or how a child might show signs that they're having compromised neurologically. Maybe there's, all the signs of increased intracranial pressure either in a baby that we talked about or in a child. Children that have spina bifida have more latex allergies, and same thing with cerebral palsy. It's just something about the exposure, the early exposure to that latex, so they have increased incidence, just for your information kind of thing. All right, meningitis. And meningitis is an infection. There's bacterial and there's viral, but bacterial is highly contagious. And there's lots of ways that you can get meningitis. It can be from an infection or something was implanted. And here it gives some ideas, a skull fracture or a lumbar puncture, or maybe a child with spina bifida or a VP shunt. But what happens is you've got inflammation and exudate, which is basically pustule material, and white blood cell accumulation. That clogs, and then you have an obstruction of the cerebral spinal fluid. You can also get rashes with a meningococcemia type of meningitis. So meningeal irritation. There's different kinds. It talks about strep, pneumonia, and meningococcal are 95% of the cases. We do have an immunization that prevents it, and that's called the Hib. So you know that Hib is started at the 1 month, and they give 3 different shots, and then you can get a Hib booster. But those are preventative, so it's important to know that we have the possibility of preventing meningitis in children. It's important that as a nurse you do obtain a health history and do your physical assessment and observe for symptoms of meningitis. Again, it can happen very fast, and the child can deteriorate very fast. It is highly contagious. So if a child comes in with meningitis, you want to get them into isolation. Isolation would be respiratory and also contact, and make sure that it's a low stimulus environment, because a child with meningitis is going to be very sensitive to light and noises, and they need to have a low environment that is quiet and darker lights, so that they don't become overstimulated. Here are some of the manifestations you're going to see. That it is abrupt, especially the bacterial, with fever and chills, headache for kids, and vomiting, some of the things that we talked about with increased intracranial pressure, and alterations in their level of consciousness. Now what this picture is showing here is they've got a couple of things that you can test for. One is called the Kernick sign, and one is called the Brzezinski sign. They're actually showing the Brzezinski. And the Brzezinski is where you, B for Brzezinski, you bring the child's head up to their chest, and they reflexively bring their knees up. So B for Brzezinski, and we'll talk about the Kernicks as well. The other thing the child might have is something called nuchal rigidity, and that's when they do have stiffness and pain in their neck. Sometimes they'll have seizures, and a few other things that you'll see here. Okay, so Brzezinski we talked about. The one that's called Kernick is a different one. With Kernick, the child's laying flat, and when you bring the child's knee up, and then you straighten it out like in a kicking motion. It's not really kicking, but it's just the knee is up, and then it's outward. That causes the child to cry out in pain. So Brzezinski is head up, and they bring their knees up. And then Kernick's is that the knee is flexed, and when you kick it out, then it causes pain. So that's 2 different signs of meningeal irritation. Now once again, these symptoms are not so strange because we talked about increased intracranial pressure. So meningitis symptoms in infants and young children are similar to what you see with increased intracranial pressure. The fever, the vomiting, the high-pitched cry, the bulging fontanelle, maybe not nuchal rigidity in the little baby, but you will see that makes it a little bit more difficult to diagnose. This child looks okay, and then they become sicker. And again, feeding and sucking problems, neurologically feeding and sucking problems can happen with little babies. They may also have poor tone, they may be just floppy, or have a poor sickly cry. And that bulging fontanelle is something to look at, but it might be later in the disease. Some other signs of meningitis that possibly could, and this could be related, that's why it's so hard to diagnose in a newborn, is that they also may be cold and jaundice and drowsy, and maybe have seizures. And so you're going, okay, what is this? Is this a liver condition, or is this something else going on? So that's why it's important to be aware that this also could be a sign of meningitis. So definitively, here's a question. A child is admitted to the pediatric unit with signs of a headache, a stiff neck, a positive Kernick's, and a fever. What intervention will the nurse employ for this client? And it says admit to an isolation room until the results of the spinal tap identify bacteria or virus. Use a television as a distractor. Inform parents that all children in the family will need a stable spinal tap or delay pain medicines. And the right answer is go ahead and put them in an isolation room, because they could be very, very contagious. So how do we determine for sure? I mean, we said that sometimes it's nonspecific in infants. Spinal or lumbar puncture. Spinal tap is what they sometimes call it, but a lumbar puncture is definitive for meningitis. And there's different ways of doing it. You can curl the child up, you can stick them over a bedside table, remember the atraumatic care. But increased white blood cells, increase in protein will be some signs that you would see particularly for that's positive for meningitis. We consider meningitis a medical emergency. There was a case about a year and a half, 2 years ago of a 14-year-old boy that died within 3 days of diagnosis. And they do need early recognition and immediate treatment. When you have a child, isolate them, and then they will do that, that spinal, the lumbar puncture, and then get them started on antibiotics. This child needs to have, in an ICU kind of situation, cardiac monitor, possibly supportive care, and really watch for decreasing intracranial pressure. They'll have fluids and seizure control. Keep them, again, in a low-key environment. So we just have to be aware that if you have someone with meningitis, it takes all of your nursing care and high-level medical care. We can prevent meningitis through immunizations. I went backwards. All right, these are some of the possible diagnoses with meningitis. I'll let you look at those. This is a summary. Nursing care is isolation and IVs and antibiotics, quiet environment like we talked about. They may not feel like eating. You just want to give them fluids, maybe some TPN until they can eat again. Another condition that we worry about, and it's been associated with taking aspirin in children with upper respiratory conditions, would be Reye Syndrome. And your ATI book talks about Reye Syndrome. There's a little blip on it. And it actually talks about 5 stages. But all the systems that are affected include the liver, the neuro, the endocrine, and the circulatory. So those are the major systems. The liver, of course, it has where we have our platelets. And so if you have the liver involved, then you might have a child that would bleed out, similar to hemophilia. What happens with the neuro system, which is deadly, and that's why it's in this particular lecture, is that you get brain encephalopathy and swelling. And so this child, again, progressively gets more and more deteriorated with every stage. So our best thing to do would be to prevent this. The slides that we have just talk about the clinical stages, the labs that are affected. Of course, our liver's going to be affected, and our coagulation times. So what do we do? And it really is holistically supportive and try to prevent. But hydration and positioning, you want to do bleeding precautions and pain control, possibly an NG tube. If respiratory gets involved, intubation and seizure precautions. It's a very scary thing. We want to prevent this as much as possible. Please refer to your ATI for some other in-depth discussion about this. Complications are this child could actually go through it and survive, but still have speech and hearing, maybe some cerebral palsy or developmental delays. Of course, the worst thing that can happen for this child is that they could die. All right, seizures. We talk about seizures in children. We also talk about it again. You might have it again in an adult, but seizures are really, what is your role in seizures? If I were to put it into a nutshell, I would say your job is to protect the child when they're having a seizure. A lot of times the questions are about that, but also observing what happens when the child's having the seizure. So timing the seizure and watching what part of the body starts to have a seizure, but also protecting that child's head and making sure the airway's intact. So there's different types of seizures, or different kind of terms, epileptic or non-epileptic, which would be like a febrile seizure. And children that are 2 and under have more possibility of febrile seizures. And some other ones as well, but it depends on the age, how they're determined. You have to evaluate, not you, but you can help in the diagnosis of seizures through your careful watching. So thorough history, skilled observation, and diagnostic testing. Sometimes they do EEGs, electrical encephalopathy, and electrograms in order to really see what the seizure activity is like. They have different terms for seizures. One is called partial, simple, or complex, and usually simple is no loss of consciousness, and complex is the one that used to be called tonic-clonic, but it's with an aura, like maybe they see a light or something like that. and there could be some alteration in level of consciousness. Now, the other thing so partial can be simple or complex. The generalized seizure, though, which is the true tonic-clonic, is what we used to call grand mal seizures, and usually not an aura before it. The person just collapses. The level of conscious deterioration is the manifestation. After a tonic-clonic, and of course this person's going to again need some protect them from injury and airway issues, but they usually have what we call a postictal phase where they're really sleepy. So if these seizures occur before 4 years old, there could be learning behaviors or possibly mental retardation or cognitive delays. There are some other kinds, like simple seizures. Sometimes you'll see maybe just the eyes blinking or the mouth just moving a little bit. So the goals of medical care are, of course, to control the seizures, to correct the cause, and to help the child have as more normal as possible. There is a term called status epilepticus, and this is a seizure that is not, the child is not coming out of. It's considered a medical emergency because it can lead to exhaustion or respiratory failure or death. So that person needs 911. They may need some kind of IV medication to pull them out of it, but it is a medical emergency. So that would be lasting more than 30 minutes, diminished consciousness. IV Valium or phenobarbital have been used before. Could be rectal Valium or lorazepam. We have a little girl at my school that we have that as the rectal Valium to be used in case of status epilepticus. These are some other drugs you want to review: Tegretol and Dilantin, Depakote and gabapentin, which are some of the drugs they've used in the past for status epilepticus. The postictal state is the state where the child is finished with their seizure. So you can put them on their side, make sure that they're able to rest for a few minutes. Sometimes the child might be incontinent during that time, but they may awaken and they may be confused for several hours. So that the child needs to be supported and not let them go off back to class or whatever, but we need to help parents understand that. So it could involve sleeping, and they may not remember what happened. So how do you assess it? You want to do a good health history if a child has a history of seizures, and we also want to do physical and neurological assessments and just see what is the seizure, what kind of seizure did they have, what did the parents observe. When you're the nurse, you want to observe the seizure. What did the child do before they had the seizure? What was their pre-seizure event, behavior, position of body? Did it change during the seizure? That's important. Was it a tonic-clonic phase? Did you just see staring? And then what happened to their face? Did they have any possibility of eyes rolling back in the back of their head? Any problems with respiration? Did they have any incontinence during that time? So what is the priority nursing intervention for a child following a tonic-clonic seizure? And that would be to keep the child in a side-lying position. So again, postictally, just observe the child, keep them on their side, let them sleep. That's kind of a repeat slide on that particular one. If they're seizure-free 2 years with a normal EEG, that's when we consider like they're kind of coming out of it. You can eventually reduce medications. They may have EEGs every 6 months to 2 years period of time. So your job is to observe, protect from injury, stay calm, and then maybe do seizure precautions. Some things that we do not do is that we don't stick anything in the child's mouth during a seizure. We don't try to hold them down during the seizure, but we do protect them from injury, kind of support their head gently and provide airway if we need to. We can turn them on their side during the seizure, but certainly right afterwards, so being with them is important. All right, the next topic we're going to talk about is cerebral palsy, or CP. CP, generally speaking, the reason children get CP is because of lack of oxygen during the birthing process. So maybe there was a problem with an extended birth, or maybe the child came out premature or had something issue going on. But a child that has CP or cerebral palsy is going to be a child that because of the lack of oxygen, is going to be kind of a floppy child, so decreased muscle tone and coordination. You can see on the slide here that it could be existing brain abnormalities or maybe prematurity like we talked about, or kernicterus. Kernicterus is where a child has high levels of bilirubin that actually cause plaques in the brain. So that's why when a child's born with physiological jaundice, they'll put them under the Billy light, but kernicterus is something we want to avoid. Another thing that can cause cerebral palsy or CP is shaken baby syndrome, and I know that you all have a little video clip on shaken baby syndrome where an adult will shake a baby and that it ruptures their blood vessels in their brain, and it also can cause damage and permanent damage. So anoxia, as you see on this slide, the next slide is 70% of the cases. About 30 to 50% of the children are mentally delayed or are mentally retarded. We also have children that have had CP that are functional and are not affected in what they can do. So what are the major goals of therapy for children with cerebral palsy? Reverse degenerative processes that have occurred, protect other children from this disease, identify problem early and promote optimum development, or take the curative medications compliantly. Obviously, the answer here is to identify the problem early and promote optimum development. One of the things that you're going to see with children with CP is that they have prolonged primitive reflexes. So whereas, for instance, the moral, which is the startle reflex, should have already gone away within that 2-month period of time, children with CP might have it past 6 months. And so that's something for us to look for, that there's delayed primitive reflexes in these children. The goals of therapy with children with CP or any chronic illness like this would be early recognition. And of course, that means that we try to identify these kids early, look at the risk factors, and see if children might have cerebral palsy. The reason we want to identify them early is so that we can promote the child's physical and psychosocial development, get the things that the parent might need, physical therapy, speech therapy, other things that they may need to, maybe some hearing issues are going on. So what can we get to them that will help them grow and develop to their full potential? And that's the third goal, is that we help them reach their potential. So it's pretty multi-professional as far as who all might be involved. You might have physical therapists involved in helping a child's motor development. A lot of times these kids have stiff or rigid muscles and tendons, and so they may need devices that help with braces. They may need extenders, trying to prevent any kind of flexion or contractures in these kids. There might be speech therapists that help them with communication issues. So we want to make sure we get a speech evaluation for these kids. Because of their motor difficulties, they may need help with just bathing and toileting and feeding, those kinds of things, which we call ADLs. What are the educational opportunities? It depends if the child is cognitively delayed, but do we want to get these kids into Head Start? Do they need some special education issues? And then make sure that they have socialization opportunities like any child that would be their age. So motor and communication, ADLs, educational and socialization are all major aims of therapy using resources that we have. Specifically, like I said, maybe support devices, extenders, or some kind of braces that they may need. Sometimes they have to have surgical corrections of tightening tendons, and so they may have to have some of those released, we call them release types of surgeries, so that they don't have contractures. And again, physical therapy. Some of the medicines you might see for children that have CP, baclofen, muscle relaxers, and then because there's seizure possibilities, some of the seizure meds that we talked about, the phenobarbital, or others that might help the children with controlling possible seizures. We have to, for nursing care, this is what NCLEX asks us to do, is always look at safety. So how can we keep children that have CP safe? Look at the environment. If they're prone to seizures, how can we keep the environment safe or have some seizure precautions? By the way, seizure precautions would be padding the rails on a bed, or keeping an environment where if the child were to fall, they wouldn't hit anything sharp. How can we help them with mobility and keeping range of motion as much as possible, and any mobility support that they might need. Feeding issues, sometimes children with CP have choking issues, so helping a parent prevent aspiration through maybe feeding carefully, slowly, burping often, and then of course family support. We've talked about chronic illness in children and how families need time for learning about the illness and realizing this is lifelong, and what kind of support can we help them get, resources can we help them get. So it's no surprise that risk for injury would be one of the diagnoses for children with CP, or impaired physical mobility, or ADL deficits, or impaired communication, nutrition issues if they have problems with swallowing, and then of course fatigue, just from the effort it takes to move their muscles. Disturbed body image as they grow older and they see themselves, and especially if they have cognitive awareness that they're teenagers that are kind of like trapped in their own bodies. And then what are the family processes? How are they coping? So those are the diagnoses. For each of those diagnoses, you could put nursing implementations down that would support that particular diagnosis. So muscular dystrophy is also one of the largest, most important single group of muscle diseases of childhood, and so ATI does talk about muscular dystrophy as well. We know that muscular dystrophy, or MD, is has genetic origins. It is gradual, progressive degeneration of the muscle fibers. So that's another important thing. So remember, muscle and neurological go together. So the child has progressive weakness and wasting of muscle groups. And one of the signs of muscular dystrophy is that they will have a child that is delayed in their walking. Most of the time kids will walk by the time they're 2 years old, but this child is having a hard time walking. So that's kind of a red flag. There is increased disability and deformity with this disease, and loss of strength. If you can test a child's labs, if you suspect that there's muscular dystrophy, they may do something called a serum CK, which is a creatine kinase. It can be diagnostic, and it would be elevated, especially in the first 2 years of their life. So Duchenne's muscular dystrophy is the most popular type. Just a little background, it's an X-linked, mostly males. About 1 in 3,600 of male births are what we've got. Let's see, another thing is that the symptoms occur usually about 3 to 5 years old. So I said there'd be delays in walking. You can also see delays. 3 to 5-year-olds are going to be running a lot and starting to do a tricycle. So delays in running and bike riding and climbing stairs. Later you're going to see an abnormal gait. And the gait that you might see would be just kind of a unsteady walking. They may have trouble rising from a sitting position or a supine position. The gait is kind of a waddling gait. They also have lordosis, and lordosis is where you've got a sway back, or the lumbar spine has a kind of a U in it. They fall frequently. The goals of care, just like with CP, are mainly supportive. For this child, you're going to see physical therapy involved and maybe some orthopedic procedures to minimize the deformity. So like I said, it's going to be multidisciplinary. You want to support the parents and do individualized therapy as much as possible with these children. Some of the parents' reaction might be shock and anger and depression, and also the children as they grow older. Generally speaking, unlike cerebral palsy or cerebral palsy, which is lack of oxygen or anoxia in many cases. A lot of times children with muscular dystrophy do not have any cognitive problems. So they're trapped in their body. It's their muscles that are failing. And sometimes these kids, as they get older, are also angry and depressed. And you as the nurse have an important role in advocating for that child and helping them reach their goals that they need. So muscular dystrophy is another one I wanted to point out to you, and that will be the last chronic disease that we talk about. So this concludes our neuro discussion today for pediatric neurological issues. Thank you.